Hello, I'm Xavier Monnet. I work in the medical intensive care unit in Paris University hospitals. And so we'll speak about monitoring of cardiac output, hemodynamic monitoring, and the influence and outcome. And I disclose the following conflicts of interest. In fact, does monitoring, hemodynamic monitoring, influence outcome? In fact, yes and no. And it basically depends on the context. I mean that there are two different settings. In the operating room, in high-risk surgical patients, in cardiac, non-cardiac surgical patients, yes, monitoring improves prognosis. Nevertheless, in the ICU, in critical ill patients, it's not the case. In the operating room, it's been very clearly demonstrated. A number of studies, the first published in the 90s, showed that monitoring cardiac output in these patients with high risk decreased the risk of complications and, in some studies and meta-analyses, decreased the risk of dying as well. Nevertheless, it was not the case in the ICU, and the majority of these studies have been conducted, as you may know, with the PA catheter now years ago. And many of these studies and all the meta-analyses inferred from these studies showed no effect of hemodynamic monitoring on prognosis in these patients. So in fact, it might be very simple. In the OR, let's use monitoring. In the ICU, we shouldn't use monitoring. No, in the ICU, hemodynamic monitoring does not influence outcome. Nevertheless, it's not that simple, and perhaps we should go further and ask some other questions beyond this one. Why were the studies negative in the ICU? Could there be some positive studies? And do we really need some positive studies? Why were the studies in the ICU negative? There are several possibilities. The first one is that actually hemodynamic monitoring is ineffective and so useless. Or perhaps it might be due to the absence of therapeutic protocols attached to the use of hemodynamic monitoring. I mean that monitoring in itself could not change prognosis. It's only the action, the protocol inferred from monitoring that may do so. The device cannot improve prognosis if you do not use that medication properly. Suppose, for instance, that you set up a study to find out that the hourly blood glucose measurement in critically ill patients is mandatory. Would you not ensure before that all participants use insulin properly in the same way, with a well-established protocol based on blood sugar? It's not only the device, it's the protocol inferred from the device. But among all the studies I showed before, none of them was based on a clear and a well-established protocol. And that's likely very important to explain these negative studies. A possibility is that there have been errors in measurements and interpretation of variables provided by the different monitoring devices. And this point is very important because, as we said, all these studies use the PA catheter, a complex monitoring device with complex interpretation of data. And this study in 1997, I mean at a time when clinicians were used to use the PA catheter, more than a half of fully trained physicians could correctly interpret a trace of pulmonary pressure and measure PaOP. How could these colleagues improve their patient's outcome by using the PA catheter if it was not well interpreted? To illustrate that, here is the example of one of the negative studies I just chose, the CAP study. Overall, as you see, the survival was not different with or without the PA catheter. Nevertheless, if the authors looked into details, There was one center in which the mortality was reduced. It was the center that had included the largest number of patients, and which was likely a team of physicians that was used to the PA catheter. It's likely that when these physicians, as experts, use the device properly, they could improve the prognosis of their patients and not otherwise. A fourth possibility for explaining the negative studies in the ICU might be that there have been some protocols, but not the right device used in these studies. In that study, in hemodynamically unstable patients, adding a monitoring to standard care delayed hemodynamic improvement and increased mortality, so a negative result. Nevertheless, which device was it? Uncalibrated pulse contour analysis, which we know for years is unreliable in patients with vasopressors and which is not indicated in these patients. And so, beyond that, could there be some positive studies? I mean that since we know why the studies were negative, perhaps it's possible to imagine what could be the ideal study we need to demonstrate an improvement with prognosis. But we do need studies with appropriate devices, with variables that should be well interpreted, studies with therapeutic protocol attached to the use of the device, and of course, it should be a good protocol. But here I think that this might be possible in the operating room, but not in the ICU. Why? Because what are the devices we may use for high-risk surgical patients in the ICU? We can use uncalibrated pulse contour analysis devices and esophageal Doppler. By contrast, in the operating room, we may use transpulmonary thermodilution devices or the PA catheters. But these devices are very different, in fact, and what are the variables they provide? In the operating room, it's quite simple, very few variables: cardiac output, stroke volume variation, and flow time corrected for Doppler. While the sophisticated devices provide many more variables. And why is it so? Because in fact, in the operating room, the questions, the hemodynamic questions, are scarce. If blood pressure decreases, especially diastolic blood pressure, we should give vasopressors. If cardiac output is low and preload responsiveness is present, I should give fluids. And actually, few questions, few variables to answer them, and this is very easy to integrate these questions and variables in a therapeutic protocol, as did almost all the studies showing benefit of monitoring in the operating room. By contrast, in the ICU, there are much more questions that are asked. To decide to give vasopressors, for instance, I look at blood pressure, but also I need to know if there is a past medical history of hypertension and how is the microcirculation. For deciding to give fluids, I need to evidence that cardiac output is low, but for interpreting cardiac output, I need to know SVO2 and urine output, and thus the renal function. And I interpret lactate with renal, but also liver function. And if I assess preload responsiveness and decide to give fluid, I must also consider the risk of fluid infusion, and so on. And the same for deciding to give iron drops. To answer these complex questions, we need several variables. It's different from the operating room. And my point is that it is not possible to integrate all these questions and all these variables in a single comprehensive protocol. I believe that no study will never show an improved prognosis with monitoring in the ICU for this reason. Finally, do we need some positive studies? Let me remind you that photoplethysmography has never has never demonstrated to improve prognosis or not in the operating room. And I'm pretty sure that all anesthesiologists over the world use photoplethysmography to monitor their patients. I do not need that monitoring has shown any change in prognosis to use it. I use it just because it allows me to see more. For instance, when I give fluid to a patient, the basic goal, you will agree with me, is to increase cardiac output. And I know that if I just monitor the simple blood pressure, it will not tell me, it will not indicate if cardiac output increases or not, because both are not correlated, and it's been very clearly demonstrated. Look at the relationship between changes in blood pressure of the bedside monitor, the simple blood pressure, and cardiac output during a fluid bolus. Look at that study by the team of Jean-Louis Vincent, not correlation at all. And in our study on the left panel, a very rough relationship. I do not need to know that monitoring improves prognosis for knowing that I just need to use cardiac output monitoring. And I guess that when you monitor the effect on plateau pressure of PEEP, when you change PEEP, you need to monitor the plateau pressure. But monitoring plateau pressure is recommended in ventilated patients, and it has never demonstrated to improve prognosis, as far as I know. So does hemodynamic monitoring influence outcome in the ICU? No. But I think that it will never do, and I'm pretty sure that it does not matter. Thank you very much for your attention.